Hello students, this is Dr. Turpin. I'm going to review some of our connective tissue disorders that fall under immunological function, which is a component that we have to cover in adult health too. You know, we have talked about some autoimmune diseases in terms of the neuromuscular function, and we have talked about, arthritis or types of that when we talked about last semester musculoskeletal, but the rheumatoid arthritis is considered caused by an autoimmune disease, and so it sort of falls into this category where it's in more than one category. And you saw that with some of the neuromuscular diseases that we just talked about as well. So anyway, just want to hit a few hot spots about this. I'm pretty sure you'll remember some of this about treatment and care and distinction between the types of arthritis. And then I want to move on and talk about lupus and fibromyalgia real quick. So just to know that when you're talking about connective tissue disease, we're looking at problems with anything from bone to cartilage, tendons, ligaments, bone marrow, and often damage related to inflammation of the immune system is the ones that we're really concentrated on. But I will mention some things about osteoarthritis just so that you're able to kind of still see the distinction between the two, but realize that it doesn't fall into that category. You also hear the term rheumatology, and so non-inflammatory diseases, like I mentioned, such as osteoarthritis, is not an autoimmune disease and is also not systemic, whereas rheumatoid arthritis, as we see further on, can be both autoimmune issues with the joints but can also be a systemic problem as well. And then we'll also talk about systemic lupus erythematosus, and so you guys can kind of differentiate some of that in terms of immune system problems. So this is just a basic review. Things we've already talked about osteoarthritis. I know you kind of remember that the joint itself becomes deformed because of lack of lining, and then you're in some types of activities that people have, and then they develop osteophytes and or cysts or remodeling of the bone that creates a situation where it's not seated properly, causes pain, and is chronic and is going to get worse and worse. Comes with age, can come from secondary from injuries, is pretty prevalent and is the leading cause of chronic disability, but yet it's not an autoimmune disease. This just kind of shows you the different process in terms of a quick picture. With osteoarthritis, you see where the cartilage has really become limited, creating more of a compression issue and friction issue, whereas rheumatoid arthritis is caused by an inflammatory process that further destroys the joint itself. So when you think about treating disease in general with osteo, this is usually older people. They're going to have joint pain. You're going to always have late in the time some crepitus. You may see some effusions in the joint, and over time they get immobile, which worsens chronic conditions that, when you think about like cardiovascular, if you're not staying active, then you have declines further in that system. So normally, just to diagnose this, you're going to do usually x-rays, and usually you're going to see some of the cysts, the osteophytes, the narrowing, and that gives you an idea that it's osteoarthritis. With rheumatoid arthritis, it's a little different, and so we're going to talk about that as well. Also remember, for osteo, it is aggravated by use or motion, and then if you let them rest, it kind of improves in terms of pain. However, the longer they stay immobile, the more stiff they get. Joints can be enlarged just because of remodeling, and some can become not mobile with contractures. And you see usually this grinding sound of crepitus late. These patients will have chronic pain, less function, and can have some toxic effects from some of their medications as well. So rheumatoid arthritis, it's a connective tissue disease. It's destructive to the joints as well, but it's considered a chronic, progressive, systemic inflammatory autoimmune disease that tends to affect primarily the synovial joints, but because it is systemic, you'll see in some of the complications and some of the symptoms can also be more throughout the whole body versus just the synovial joints. And you have basically autoantibodies that are forming and attacking healthy tissue, causing inflammation. Rheumatoid affects approximately 1% of the population, and females are 2.5 times more likely to get it than males. You see the onset is usually much younger, 30 to 50 years of age, and it is prevalent in Pima and Chippewa Indians, which is just a different presentation as to why that might be. Again, it's chronic and it's systemic and it's autoimmune. It is not quite sure, they're not still quite sure about genetics and environmental factors that can maybe be adding to this or causing it to occur more often. They do know that first degree relatives of rheumatoid arthritis patients have a 1.5 times higher risk to get it than the general population. And we know that it's an antigen triggers an immune response that kind of fails to distinguish the self from non-self and attacks the synovial joints. So, of course, manifestations include joint pain, swelling in a symmetrical fashion, which is very common in rheumatoid arthritis. So if it's attacking one wrist, it's affecting both wrists, both ankles, or both knees. And so sometimes in osteo, it's easier to make that distinction, at least to diagnose it, because it may just not be bilateral. And so then they do some x-rays and they can kind of tell the difference. So the patho for rheumatology, I won't read it to you, but you can kind of just visually see that it's attacking the synovial joints, and the actual development of a pannus occurs, and then it really just obliterates the whole articular space, and you finally just get to where it's breaking down the bone itself. You may get bogginess in the bone area, and then the resultant bone that is there on each end gets very osteoporotic. So again, the onset is somewhat insidious with it. Sometimes people have vague complaints of joint pain overall, muscle pain. Early into the disease, they tend to have joint stiffness, swelling, pain, fatigue, general weakness. So, again, you think about it, it's attacking, the immune system is attacking itself. So it's not just like, oh, my right knee is aching. It's really like an overall sense that it's systemically affecting people. And then joints become progressively inflamed. They become very painful, where you see synovitis, and then you have joint destruction becoming more obvious as it goes along. These are some of the typical deformities that you may see, and then you may see people having injury because they get up to try to do something or lift something, and the joint itself just totally gives way and or becomes like just not functioning as a joint any longer. This is kind of a breakdown between systemic and joint problems. We've already talked about the joint. On the systemic side, fatigue, anorexia or lack of appetite, weight loss, some of this non-specific complaints of aching and stiffness. They may even experience fever and rheumatoid nodules that I'm going to mention a little bit more about in a second. This is a good breakdown when you're trying to look at what would typically be involved in trying to make an assessment of somebody. Usually, osteoarthritis patients, they will have some stiffness, but usually if they get moving, that stiffness will last less than 30 minutes. Rheumatoid arthritis patients, it's usually much longer periods of stiffness. And then you can kind of see the different joints that are more involved. And you don't typically see symmetrical joint involvement with osteo. Although, as we talked about before, if somebody's got a really bad hip on one side and they've walked on it for a long period of time and walked and put more pressure on the other side, then they can get some problems on the other side. But usually that happens over time, not, instantly having the same problems bilaterally right when it occurs. These are just some typical assessments. Besides the physical oversight, the diagnosis for this is sometimes kind of difficult. So there's a point system that's developed that looks at anything from pain in specific joints by palpation to a series of laboratory tests. But a lot of the tests, I will caution you that just because they show a certain value, it doesn't necessarily confirm rheumatoid arthritis. For example, you can have an elevated C-reactive protein or SED rate that will let you know if that's positive, if it's elevated, that there's an inflammatory process. But what is that inflammatory process? Is that necessarily rheumatoid arthritis, or is it some other autoimmune problem going on? Also with rheumatoid factor, anti-nuclear antibody titers, and anti-cyclic citrulinated peptides, if those come back positive, it may indicate RA, or again, it could be another autoimmune disease. And then some doctors will order a complement C3 and C4. The literature's kind of back and forth on that. That's not covered in your book, but you do see that ordered sometimes. Some doctors say that it shows the severity of disease, and then there's other studies that say that doesn't pan out. So just know you might see that ordered from time to time. Again, that X-ray may go into more detail. CT, they may do an arthrocentesis to pull off some of that fluid and test it between the joint, MRIs, and bone scans. In terms of drug therapy, you will see disease-modifying anti-rheumatic drugs. We mentioned methotrexate with one of our other neuromuscular diseases. Sometimes can be considered a chemotherapy as well. In this case, it's given one time a week, and it can be PO, sub-Q, or IM. It's considered a first-line drug. There are several other DMARDs in your book, but usually this is the first line. Once methotrexate has kind of not been as effective, they may change to some different ones. It does have some risk of hepatotoxicity. Patients may develop oral lesions, and you will often see them ordered on folic acid, PO, as a method to kind of prevent the development of those lesions. And then you have to be really concerned and watch their renal function with methotrexate use as well. They may be on NSAIDs to control inflammation. Of course, with the pain, they may be on analgesics. They may be ordered on biological response modifiers, and those are usually given IV or sub-Q, and that's just another way to interrupt the immune response and maybe lessen the effect of that.